Risk is one of the three elements that's used in medical decision-making when we are determining the level of service for an evaluation and management code. Evaluation and management is a very common service, so it's something that the majority of coders are going to have to deal with and know all of the intricacies for. However, unlike other services and codes, E&M is not particularly straightforward. So in this video of my series on evaluation and management coding, we're going to focus on the risk aspect. Hey there, I'm Victoria. I'm a medical coder, auditor, educator, and content creator. And on my channel, I provide tips, tricks, and tutorials to help you be successful in a medical coding career. If you haven't already, I highly encourage you to subscribe, hit that notification bell so you can get alerts when I post new episodes. Today, we are discussing the risk element in evaluation and management coding, or more specifically, the risk of complications and/or morbidity or mortality in patient management. Now, first off, what do we mean by risk of complications? This is another one where the AMA has given us some really good definitions in their guide. I am going to link that below. So the risk of complications and/or morbidity or mortality of patient management includes decisions made at the encounter associated with diagnostic procedures and treatments. This also includes possible management options that were selected and considered, but we ultimately wound up not selecting them. So we're like, oh, we could do this, we could do this, we could do this, and then went, oh, you know what, maybe we won't do those. Even if we select something that, is a lower risk, because we had to consider those other options, they're still incorporated in here after shared decision making with the patient or the patient's family. So for example, decision about hospitalization includes consideration of alternate levels of care. Examples may include a psychiatric patient with a sufficient degree of support in the outpatient setting, or the decision to not hospitalize a patient with advanced dementia with an acute condition that would generally warrant inpatient care, but instead we are going to go towards palliative treatment. Now here's the thing, we have this definition of the whole risk of complications, but then we also have a separate definition of what is risk. And I feel like this is worded a little strangely, so hang in there with me. So risk is defined as the probability and/or consequences of an event. The assessment of the level of risk is affected by the nature of the event under consideration. For example, a low probability of death may be high risk, whereas a high chance of a minor self-limited adverse effective treatment may be low risk. Or in other words, something that has a low risk of death, depending on other factors and things going on, it could be low risk, it could be high risk. Definitions of risk are based on the usual behavior and thought processes of a physician or other qualified healthcare professional in the same specialty. Trained clinicians apply common language usage meanings to terms such as high, medium, low, or minimal risk, and do not require quantification for these definitions, although quantifications may be provided when evidence-based medicine has established probabilities. For the purposes of medical decision-making, level of risk is based upon consequences of the problems addressed at that encounter when appropriately treated. Risk also includes medical decision-making needed to initiate or forego further testing, treatment, or hospitalization. The risk of patient management criteria applies to the patient management decisions made by the reporting physician or other qualified healthcare professional as part of the reported encounter. Basically saying that just because maybe someone else is evaluating the patient for a very high-risk condition, if they're the one that's managing that condition, and this other physician is maybe managing, something lower risk, maybe their high blood pressure, they don't get credit for the fact that the cardiologist is maybe managing a very complex cardiological problem because they're just managing something simple. For the risk section, we have minimal, low, moderate, and high, and they give us some examples, but the interesting thing is they don't need to fit exactly what is in here. They are clearly examples only. And in that definition we just talked about, the provider could technically just put low, moderate, and high, but of course they're going to need some clinical backing of why they did that. They can't just assign high to every patient that walks through their door. There has to be some logical medical reasoning behind it. And what's listed in this component is very reminiscent of the management options selected that we used to have in the risk table for our 95 and 97 guidelines. Minimal and low don't actually provide us any examples. We only start seeing examples when we get into the moderate category. So again, they are examples only, so you might have questions, hey Victoria, if the provider documents blah, 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 does that count as moderate or high? I can only provide my opinion on this because they are subjective. And the opinion of Victoria really doesn't hold much water. The first example for moderate is prescription drug management, and there is a little bit of debate that goes on with prescription drug management. I've worked with my Medicare contractor in the past, and they have told me and provided clear direction in writing on their website that says they do not count prescription drug management as an over-the-counter medicine that's given at prescription strength. For example, a provider could prescribe a prescription strength of ibuprofen, like 600 milligrams, but a patient can go and purchase that over the counter at their drugstore and get the 200 milligram tabs and just take 3 of them. But again, there's differences of opinions on this. There might be differences in how different insurances or Medicare contractors view it, so make sure that you're applying the right regulations for your area. The next are decision for surgeries. So decision regarding minor surgery with identified patient or procedure risk factors, and then decision regarding elective major surgery without identified patient or procedure risk factors. So we have a couple of things we need to kind of clarify and define here. First is what is a minor surgery versus a major surgery. And when these guidelines, these updated guidelines first came out, everyone's assumption was, oh, we'll just go by global days. If it's a 0 or 10-day global day, that's what we consider a minor surgery. If it's a 90-day, that's what we consider a major surgery. And the AMA came back and said, well, we don't really go by CMS because, it's really up to the provider's clinical definitions of what they want to consider a minor or major surgery. So technically it doesn't go by global definition, although I don't think that precludes your organization setting a policy and going, for our purposes of how we code evaluation and management, we're going to go by global period definitions. And then what do we consider an elective surgery? So elective procedures and emergent or urgent procedures describe the timing of a procedure when the timing is related to the patient's condition. An elective procedure is typically planned in advance, scheduled for weeks later, while an emergent procedure is typically performed immediately or with minimal delay to allow for patient stabilization. Both elective and emergent procedures may be minor or major procedures. So if a patient's appendix is about to rupture, that would be an urgent procedure. If a patient comes in and we go, oh, you have gallstones and we're going to schedule you in a couple of weeks to come and get your gallbladder taken out because it's not, heavily infected and inflamed and we're scheduling it for later, that would be an elective procedure. Elective isn't the same as medically necessary. So even though it's medically necessary, we still can consider it elective because it's not an urgent, like we have to do this right now type of situation. And when we talk about risk factors are the risk of the patient and procedure. The next is if their diagnosis and treatment options are significantly limited by social determinants of health. Now, social determinants of health are things like economic and social conditions that can influence the health of that patient. This could be things like food and housing insecurity. Every time I think about social determinants of health, though, I remember how some years ago my local coding chapter had someone from one of the associations that helps our homeless community come and speak at our event. And she talked about some of the barriers that these people face, like when it relates to their medical care. So for example, if they are going to apply for medical assistance, a lot of them, they've lost everything. They don't have their birth certificate. They don't have their social security card. They need those to apply for an ID that they also don't have. So trying to figure those things out. And in regards to like patient management, I think about how they said, patients who have diabetes, they need to be on insulin. Insulin needs to be refrigerated. Well, if they don't have a home, where are they going to keep an insulated medication? So they would work with, local shelters, or they would work with local churches and see if they had space that they could safely store their refrigerated medications. So those are the examples only that we have for the moderate category. So there might be things that don't quite fit in there, but if you kind of evaluate their risk and think, yeah, this is kind of similar to prescription drug management, or maybe, they can't do this because this is on the same kind of level, you could still consider it in moderate category, even though it doesn't fit exactly what that example is. So where do we get into our high risk of complications? So here's your examples for high. First is drug therapy requiring intensive monitoring for toxicity. And of course, we're going to have some clarifications about what that means. Like, what do we consider intensive monitoring? So a drug that requires intensive monitoring is a therapeutic agent that has the potential to cause serious morbidity or death. The monitoring is performed for assessment of the adverse effects, not for the assessment of therapeutic efficacy, not to make sure that the medication is working, to make sure that we're not having adverse effects. The monitoring should be that which is generally accepted practice for the agent, but may be patient-specific in some cases. Intensive monitoring may be long-term or short-term. Long-term intensive monitoring is not performed less than quarterly. The monitoring may be performed with a laboratory test, a physiologic test, or imaging. Monitoring by history or examination does not qualify. The monitoring affects the level of medical decision-making in an encounter in which it is considered in the management of the patient. Again, in this encounter. An example may be monitoring for cytopenia in the use of an anti-neoplastic agent between dose cycles. Examples of monitoring that do not qualify include monitoring glucose levels during insulin therapy as the primary reason is therapeutic, or annual electrolytes and renal function for a patient on a diuretic as the frequency does not meet the threshold. The next two examples are decision regarding elective major surgery with identified patient or procedure risk factors, decision regarding emergency major surgery, and again, remember, we're not going by global periods here. Decision regarding hospitalization or escalation of hospital level of care, decision not to resuscitate due to poor prognosis, and then parenteral controlled substances. The AMA doesn't really define parenteral controlled substances, and I've had coders in the past that kind of struggle with this because it's hard to determine when you're looking at 100 different medications today what are considered controlled substances and not. Parenteral, as a reminder, that's anything that's not taken by mouth, so things like injections. So a parenteral controlled substance is a medication not by mouth that is considered a controlled substance. These could be things like opioids, stimulants, depressants, hallucinogens, or anabolic steroids. Sometimes if you do a really good Google search, you can find a nice listing of the different types of controlled substances that we could possibly fit into that category. So that's it for that risk portion of evaluation and management. In the next video, we will talk about time considerations. And once we've gone through all the components and the time, I think it's time to then put it all together and maybe go over some examples. So I will see you guys in the next video. And until then, just keep on coding on.